Anything like Lonnie.
He's not here.
How you doing?
Good, how are you?
Yeah.
Is that the one that wrote the book? Okay. So when she looks at me, she seems to go one more time, and they'll play. That's not something that you do. Yeah.
Let's get now.
Does it automatically, but if you do, as soon as you get on the slide, it'll automatically play. This way she has. That's like, why are you playing? Why are you playing?
And I thought it was you too.
Yeah, no,
This whole time.
I said, let me go ahead and explain this shit right now. Yeah, all she has to do is get one more time. And then once she finishes hers, then it goes to the person in the front.
It moves. Okay.
Yeah.
Thank you.
You're welcome. Okay, 12:30. I'm obviously I love this conversation. This is why you better leave me alone because somebody else is doing what you're saying. They don't know what the fuck they're doing. Then leave me alone. Then leave me alone. I got one yesterday. The other day, my mom was like, "They fucking with you, aren't they?" I was like, "Yep." She was like, "Get your shit and come up there."
Your mom don't play.
No, she don't. Do I need to get up and get my hair together? Because we go to the stars. She was like, I won't put no earrings on or nothing, so we can just go ahead. I'm gonna scoop this flag over some.
I know, I can't even know. I'm great.
She responded about the blue folders, but she was like, just take the blue folder and.
She responded?
Yeah.
Well, where is it?
I'll tell you what she said.
What blue folder?
I don't want to say it. She said.
family?
Don't know if you travel.
Oh, you've been traveling? Oh,
Like crazy with the end of the year.
well, at least it's before the holidays.
And it's got to do with the holidays.
You took, oh, no.
I have to operate 2 days.
Where are you traveling to? Where are you going?
Hopefully, and then I have to operate at night with Vietnam King.
Oh, okay. Difference.
Time to It starts, but gotta do what you gotta do. Should never find a CPA. Should be a short meeting today, huh?
Mm-hmm.
And then always easy. July, August. All the
Yeah.
strategy, budget.
Yes.
To eat yet?
We already ate, yes, thank you.
Test 1, 2, 3.
Everybody coming today?
That I know of, yeah.
Angela, you
Good. How about you?
same as always.
What is that? That's loaded.
Assume positive intent.
All right.
Never from compliance. Never. It's always laced. You got a good one today.
Oh, yeah?
You got a good one for us today? Okay, good. I need some positivity.
Listen. Yeah, I'm digging deep, but we're good.
Oh no.
I blame it on the commute. It's all right.
Hey, that's everybody these days.
Seriously.
Test 1, 2, 3.
Can we meet before turkey talk?
we have a quorum, so we're going to start our meeting today. Welcome. We'd like to invite Ms. McDonald for our prayer and the Pledge of Allegiance.
Good afternoon, everyone. Let us pray. Gracious God, we thank you for the gifts you've placed within each of us, the abilities, experiences, and passions that enable us to serve our community with purpose. As we plan, create, and collaborate today, grant us clarity of mind, openness of heart, and steadiness of spirit. May our conversations be thoughtful, may our decisions be wise, and may our work reflect the very best of who we are. Let unity guide us, let truth ground us, and let compassion shape every action we take together. Amen. Amen. And now please stand for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I don't believe we have any citizen register.
We don't.
We're going to move to the next item, which is the approval of the minutes. Second. Any comment? If not, I'd like to have all in favor signify aye. Aye. Any opposed? Motion pass. The next item is the board chair. We don't have a lot, so before we begin today's agenda, I want to start by thanking Dr. Duncan and her team for putting together a Veterans Day ceremony on Tuesday that was not only meaningful but uplifting. It was one of those mornings that reminds you that what's special about JPS, the people, the heart, and the sense of purpose we share. We opened with the Crowley ISD Junior ROTC Color Guard, and those young cadets carry our nation's color with a level of pride and patriotism far beyond their age. They brought an energy to the room that set the tone right away, respectfully, hopefully, and full of gratitude. Then one of our own, Reverend Emerson, offered the invocation. Many of you know Ralph is a Vietnam War veteran. He served in the Army and was in the country. That generation didn't always come home to applause and appreciation. Many returned quietly, carrying an experience that stayed with them for life. So I said to Ralph what every Vietnam veteran deserves to hear. Welcome home, sir. And you can feel how much that matters. Sometimes the simplest words carry the deepest meaning. We also heard from Major Deborah Stewart, one of our nurses, a retired officer of the U.S. Army Nurse Corps. Over 22 years of service, she spoke with honesty and heart, reminding us that the wounds of war, whether physical or invisible, don't disappear when the uniform folds away. Yet she also brought strength and hope as she continued to advocate for veterans and support those still fighting battles we cannot always see. One moment that stood out was the single empty chair placed in the front of the room. A quiet symbol, but powerful. It represents our POWs, those still missing in action, and all who paid the ultimate price for our freedom. It also honored the family who waited, prayed, and endured the deepest uncertainty. That chair reminded us why we gather and why we honor. To our JPS veterans, our service to the country didn't end. It simply changed mission. Today, you serve through compassion, healing, protection, and leadership. And you do it with the same commitment and courage you show in uniform. We are proud of you and grateful for your heart you bring to this organization. I also want to thank Ralph, Dorothy, Mitra, and Alan for being there. Your presence meant a lot to our staff, and I hope we continue showing up, not just with our words, but with our time, our support, and our appreciation throughout the year. And on a lighter note, I want to remind everybody that the JPS Board of Managers Christmas dinner holiday party will be on Saturday, December 6th, from 5:30 to 8:30 at the Mira Vista Country Club. I hope all of you can join. It's always good to celebrate, laugh a little, and spend time together outside of the board business. That concludes my report, and I'm going to turn it over to our CEO.
Thank you, Mr. Chairman. Okay. Welcome, board members. As always, we get loud. Okay, what are we going to get loud about today? Okay, our second annual White Coat Gala was held on October 19th. I know there were a number of you that were there. Thank you. It was a great celebration of our mission and the people who bring it to life every day. Thanks to the generosity of our community and our foundation, the event raised more than $250,000 to support programs that directly benefit our patients and our staff. During that ceremony, we were able to give 2 awards. The first one was the Community Impact Award that went to Cook Children's Healthcare System. As many, if not all of you know, Cook and JPS have partnered together with the Las Vegas Trail, and that was an amazing partnership that went on, and we felt this was a very meaningful way to thank them for reaching out to us. And then the JPS Physician Recognition Award was presented to Dr. Russell Wagner. And Dr. Wagner, for over 30 years, over 3 decades, has really shaped the future of orthopedic medicine here at JPS and was recognized by his peers. I want to give a special nod to our JPS board member and foundation board liaison, Alan Roger, for your efforts in supporting the foundation board. I know we named you as board liaison, and it was in seconds that you really jumped in and really became a part of not only demonstrating the heart that you have for philanthropy, but the heart that you have for JPS. So we want to really recognize you for the work that you did that helped with this gala. Alan's looking at me like, okay. On October 22nd, our trauma team hosted this year's Trauma Symposium. The theme, Champions of Level 1 Trauma, from the field to the front line, tied perfectly to the excitement building around next summer's World Cup here in North Texas. It was a great way to highlight what makes our trauma program so strong: teamwork, precision, and communication under pressure. Our keynote speaker, Jack Becker, a combat-decorated naval aviator, gave a powerful talk about leadership, adaptability, and trust. We see that those same qualities define our trauma team every single day. The symposium brought together clinicians from JPS and across the region to share ideas, learn from one another, and strengthen trauma care statewide. That commitment to excellence is actually getting noticed. I'm excited to announce that JPS has been named the Texas EMS 2025 Designated Facility of the Year by the Texas Department of State Health Services. This award recognizes our collaboration with Hendrick Medical Center in Abilene. Our team has supported their journey from a level 3 to a level 2 trauma designation through mentorship, case reviews, and surgeon-to-surgeon communication. This award shows how JPS extends its mission beyond its own walls, and we continue to improve outcomes and save lives not only here at JPS, but across Texas. And on November 24th, 5th, I believe, is when we will officially receive that award, but I did want the board to hear this news. Okay, speaking of fun, aren't these so cute? This is our NICU during Halloween, in which our team members dressed up our precious little babies here. And these were actually out on social media. Speaking of Halloween, we actually have a pumpkin decorating contest. You can see some of the creative work that goes on across the organization. But I want you to look at our pet therapy dogs there. Thing 1 and Thing 2. Just goes to show you our engagement across the organization, including everyone being inclusive. And then I'm not going to go through, but these are some pictures of our Veterans Day. Again, want to thank those board members that did attend the event. This year, I don't know, it just really touched me in a different way. I don't know if it's because of what's going on across the nation, but it was extremely heartfelt. But she wasn't she, from our OR? Yeah, she was great.
And the young lady who sang, she could sing.
Corey's one of our team members, didn't she? We've got a couple of amazing, but she did an amazing job. She did. And with that, Mr. Chair, I turn it back over to you.
Thank you, ma'am. The next item is the report from our medical executive team staff committee. Dr. Casey. Is this typical normal stuff, or do we have anything that we need to? I guess this required board approval, so may have. Second. All in favor, signify aye. Aye. Any opposed? Motion pass. The next item on the agenda is the Finance, Planning, and Investment Committee. Mr. Austin?
Thank you, Mr. Chairman. So on October 23rd, the Finance, Planning, and Investment Committee met. That was led by Brian Greer, who gave us the 6-month outlook for the master facility plan, campus phasing. So the updates that were provided started with the ambulance bay relocation is in progress. So that is a temporary situation where we are relocating the existing ambulance bay and phasing plans for the new hospital. The demolition of the Morphy Garage has begun, and this is going to be the future central utility plant, also known as the CUP. Preparation for the medical office building has begun, and excavation for that is expected to be January, also known as the MOB. Site work for the new hospital will begin once the parking garage opens in spring of 2026. So we appreciate Brian for those updates. Then we went on to our CFO, Kim Hodgkinson, who provided the financial update for the month of September, notating that income was $9.1 million for the month, which exceeded budget by $0.8 million. The top drivers included strong inpatient and outpatient volumes, retail pharmacy revenue, and strong labor management. Fiscal year 2025 operating margin was 7.9% compared to the budgeted operating margin of 2.1%. While the operating margin exceeded budget, it was lower than the prior year's operating margin of 11.4%. The change in performance year to year is primarily due to the reduction of Medicaid DSH funding and the reduction of tax revenue. Beyond that, headwinds related to federal, state, and local programs which continued in the fiscal year 2026. And our financial goals and all metrics were reviewed, except the operating revenue per adjusted patient day and length of stay. The length of stay appears to be a challenge, and staff is continuously working on solutions. On to the audit. It's well underway. That'll be presented on the 2025 board meeting. The audit is being conducted by Forvis Mazars, if I'm pronouncing that correctly, which I had the opportunity to meet with and was very pleased with their services. So I think that's well underway, and we should know more towards the end of the year. The committee approved the September 2025 unaudited financial report, and there were 7 contracts that were presented and approved for board approval that we'll be discussing here today. So that is my financial update.
Thank you, sir. And the next report is, or any question for the report? If not, the next report is from Quality and Patient Safety Committee. Dr. Allen?
Thank you, Chair. We met right after the Finance Committee on the October 23rd Quality and Committee meeting. We always start these meetings with a video to kind of highlight how well JPS does at quality initiatives. And this one happened to kind of tie into the presentation. It was about a patient who had an amputation and subsequently developed a MRSA infection in the limb. And so he was started in the outpatient antibiotic treatment program, which allowed him to receive IV antibiotics at home. And so he could go home, maintain his independence, and avoid a prolonged hospital stay. And that led into a presentation by our Dr. Dara Simon and Selena Garcia, who's the director of that clinic, who presented an overview of the program. For those of you who weren't there, it's a program where our patients can go home and they learn themselves how to give themselves IV antibiotics through a PICC line, and then they come into the clinic periodically to get the PICC line cleaned and to do lab work so that our infectious disease doctors can monitor their progress. And this program really increases a lot of autonomy for the patient, but it leads to a lot of benefits for the hospital, including reduced hospital stays, significant cost savings, and it also really helps with the monitoring of the physicians in these patients. They don't get lost to follow-up. Key outcomes were bed days saved, cost avoidance, high patient satisfaction, and expanded outpatient capabilities. And then we had a discussion on how we can grow this program in the future. Right now, it's only available to JPS Connections patients, but it would benefit any patient that falls into this patient population. We moved on then to the JPS quality dashboard. Dr. Badamusi just kind of reviewed the overall quality dashboard, which for y'all who are not familiar with it, it tracks 34 different metrics over 70 domains and just kind of shows the breadth of quality that we're tracking and monitoring over the whole healthcare system. We did kind of focus on post-operative complication rates, maternal quality metrics, and central line associated bloodstream infections. And then Dr. Badamusi spoke on the action plans that we have on each of these areas. Then we moved to discuss some of the network quality updates. And so Dr. Badamusi has been working with all of the different departments of this hospital system and working to improve their quality metrics. And he presented on the sound hospice and the sound anesthesia performance, nutritional services, and the antimicrobial stewardship program. And then the council also reviewed the latest CMS star ratings. And CMS star ratings, which is the Medicare rating of the hospital system, it's based on a billion different things, primarily quality over a lot of different areas. And JPS this year has achieved a 4-star rating, which is huge and very hard for a hospital system of this size. New to our quality meeting, Dr. Casey presented, who's the president of the medical staff, he presented an overview of the delineation of privileges along with the credentialing and privileging process at JPS, just to educate those of us on board. It goes from the initial application through final approval, and he emphasized the parallel yet distinct requirements for physicians and advanced practice providers, that's nurse practitioners and PAs. And then on consent, we have approval of 11 delineation of privilege forms
Thank you very much. That is a very, very great accomplishment for achieving the 4-star rating. It's very, very hard. All right. Then the next item on the agenda is the result of the fiscal 2025 strategic scorecard. Madam COO.
All right, thank you. Oh, this is super. All right, I'm going to first start off with our FY25 strategic scorecard performance, otherwise known as our AIP plan. This past year, we approved 2 different scorecards. One was for staff, another one was for executives. This is the final scorecard for staff. As you can see, with patient experience, we ended at 78.9, which sits between target and stretch. We made positive improvements in every single area. Team engagement, clinician engagement, we ended at 4.08. While not statistically significant, it did not achieve threshold, so we did not have any achievement on that. Employee engagement, this was a tough one. As we know, we were already sitting really high, but we actually made additional gains here. We moved to 4.35, which is slightly above target. Quality was our Africa measure. This is the pay for performance quality component of CHIRP through the state HHSC. It contains 6 different quality measures. It's a bundle. We ended with a composite score of 10, so we did not achieve this metric. I do want to point out, in order to get the financial achievement from the state, you had to achieve 9 points, which we achieved, so we didn't lose any money with the state, but we did not achieve on the scorecard. We do know we have some opportunity with C-section and readmission as part of this component, and I'll talk a little bit more about that when I talk about the FY26 goals. And then finally, for financial was the external funding bundle. It included foundation grants, clinical trials, as well as a government funding programs, and here we achieved stretched. The executive scorecard had 2 additional metrics. I won't go through the top part because they're all the same, but you can see off there at the bottom, we added the supply costs operating margin, which we ended at 7.9%, which you all know, which exceeded stretch. Supply cost per APD, we ended, which is adjusted patient day, we ended a little bit better than target. And then FTEs per APD, we made some progress over the year with achieving stretch, but we know we have some continued opportunity and work to do there. So overall, we did well this past year, and am very proud of the work that our teams did to achieve the goals that we did. All right, I will move on to now the FY26 scorecard metrics. I really want to start off with really a reminder as to how we get here in this process. This past summer of 25, we started leadership sessions. We review our current strategic plan. We also begin to review any priorities we have for the coming year, and we start to develop draft metrics for this scorecard. As always, our goals are going to always align with our strategic plan. We also work with our internal data analytics team. They are the statisticians that help us with setting some of the performance targets. Additionally, we work with external partners. For example, Press Ganey helps us with patient experience, Gallup with team engagement. We then have additional vetting by leaders. We have several meetings with the subject matter experts in these various areas to finalize those goals and also look at the performance metrics. Also, I want to thank the board committee chairs and co-chairs for your assistance in meeting with us regarding your goals for your various areas. Appreciate your support and your approval. Thank you, Dorothy and Blake, reviewing the HR metrics, Dr. Holland for quality and patient experience, Dustin and Demetria for helping us go through the financial metrics, and then of course, DT, thank you for your leadership. Finally, as a reminder, all staff and leaders can impact these goals as well as receive the benefit from any achievements. The categories for the scorecard metrics for FY '26 as recommended include all these categories. So team engagement, again, looking at clinician and employee engagement, looking at introducing first-year employee turnover. For patient experience, the patient experience overall rating bundle. Quality is a new clinical quality composite. It's a modified bundle that I'll talk a little bit more about in a minute. And then financial, operating margin, and looking at labor a little bit differently, labor expense ratio. We are confident in these goals, and we've selected metrics that will help drive performance across the district. I'll start off with team engagement. You know, you have to have high engagement in order to derive any sort of performance like productivity, patient outcomes, workforce retention. Clinician engagement, I mentioned earlier, we completed at 4.08. We know there's opportunity for improvement. I will note, as you see here, we are in the 77th percentile rank currently. Setting target would be 4.18, which get us to the 84th, and stretch 4.23, the 87th percentile rank. Employee engagement, can't say it enough. We perform strong. Our team continues to perform strong. Where we ended last year was the 96th percentile, so target at 4.38 would be at the 97th percentile rank. Stretch 4.41 would end us at the 98th percentile rank. All right, I'll move on to HR metrics. The last HR metric, I'm sorry. This is a new metric. This was something that we've always carried in the HR committee. We've always had it on those secondary metrics. We think that it's time to move this up to the main scorecard. Why? There's a cost to turnover. It's reported, if you read any research out there, it's over $55,000 to replace a nurse. We also know that premium labor, like overtime when you have vacancies, is also a high cost. There's an association with patient experience and patient outcomes consistent with dedicated workforce. We also know that that stability is important for our operations. If an employee can make the first year mark, they are likely to stay at least 3 years, and so that first year is really important. When we look at benchmarking data across the country, we currently sit at a little bit better than median, so we know there's some opportunity here. Target would be set at 28.18%, which would be a 3.5% reduction. Stretch at 26.28 would be a 10% reduction. The next metric I'll review is patient experience. As a reminder, this is a composite metric. It includes all care areas, inpatient, outpatient, surgery, the emergency department, both inpatient and outpatient behavioral health, as well as ancillary services, including lab, radiology, outpatient therapy. This is a quality metric. We know the value in positive patient experience is significant. There's a correlation to improved outcomes as well as adherence to their medical plan and advice. We also know that performance is important for many other programs like CMS star ratings, Leapfrog, and our insurance payers pay attention to this as well with value-based contracts. Target would be set at 80.9 and stretch 81.9. Move on to an additional quality metric. This is the partial carryover metric from our Africa goal last year. So 2 of the measures from Africa where we saw we needed some additional improvement and some work done is around C-section rate and readmission rate. We also have added PSI 90, which Dr. Batamosi speaks to at every quality committee and the value of PSI 90. And then we're also looking at hypertension control for this complete bundle. We feel like this is a good measure as it's balanced across inpatient, outpatient, and our women's areas. And again, like patient experience, it is part of other reporting for CMS, Joint Commission, Leapfrog, and much more. I will go into the composite a little bit in more detail with this slide. So much like the Africa, there's assigned points based on where you land with each particular component of the bundle. You can see C-section right there. We would want to achieve, obviously, improve our baseline, 27.94. would get you 1.2 points for less than 26.5, and then stretch less than 25.20. 30-day all-cause unplanned readmission rate, again, following the same methodology, you can see where you would achieve threshold, target, and stretch based on that performance. PSI 90, the patient safety and adverse events composite, which is the CMS patient safety indicators, includes many metrics like pressure ulcer rate, post-operative sepsis rate, post-operative respiratory failure rate. You can see here with your score, threshold, again, would be less than 1.9, target less than 1.8, stretch less than 1.7. And last is hypertension. Hypertension control we feel like is very important. It's the #1 diagnosis across our patient population. We know people who have hypertension that's uncontrolled leads to stroke, heart attacks, kidney disease, and many other issues and complications. So I'll go back to how this then comes back together. You can see here, when you achieve all those different things, you get an overall composite score to achieve threshold, target, and stretch, as shown. The last two metrics are financial metrics. First is operating margin. We're all very familiar with this. This is important as we need to continue to fund the future fund. You can see here baseline was 7.9% from last year. Threshold at 1.5% would be at our budget, current FY26. If we were to achieve a 2.9% operating margin, that would give us a $27 million improvement. And then stretch at a 4% operating margin would give us a $47 million improvement over budget. The last financial metric is the labor expense ratio. I mentioned earlier, this is a bit modified from what we did last year. Last year, we were looking at FTEs per adjusted patient day. This will help us account for any type of labor cost, regardless of the type of FTE. So this is important as we're looking to continue to control cost, and labor does account for about half of our operating cost. So here you would see target would be at 79.4, which is a $24 million improvement, and stretch 79%, which is a $29 million improvement. So the last slide here is our summary strategic scorecard for FY26 with everything that I just spoke about before, and asking for your approval.
Jill, I have some questions.
Okay.
I noticed on one of the slides, slide 21, the clinical quality composite, it's got 1.2 point, 3 points for threshold, target, stretch. Does that apply to all the slides equally? They're all threshold 1 point?
Yes.
But that's the only slide I saw that on, that header.
Yes, this is the only one that it applies to as a composite.
Okay, so that leads in, so you add those up and then that gets to the.
That gets to this.
That's how you get your points.
Exactly.
6, 7, and 9.
Exactly.
Okay, that answers those two. For physician engagement, which is on slide, our clinician engagement, which includes APPs, correct?
It does.
Slide 17. Last year, our threshold was 4.13.
Mm-hmm.
And we didn't make it.
We did not.
And yet, this year, you're proposing to lower it to where we ended up last year. I think we should leave that at 4.13. I don't think we should be lowering our goal for clinician engagement because we didn't make it last year. That'd be my proposed change to that instead of 4.13.
But you increase your target more than that. And you tell that clinician engagement.
Yeah, he's saying because the baseline's where we end. The
Yeah, 4.0 is where we ended.
improvement over self. Right. I said baseline's where we ended the year, and would we not want to improve over where we ended the year? Not where we should have ended the year. That's, yeah.
We didn't make that, but I don't think because we failed to make that, we should lower that 4.08 just to make the starting point where we finish. I think we should still try to, the target and stretch are fine. The stretch is a little lower, the target's a little higher. But I don't think our threshold should be set at, if you consider 4.08 to be a failing grade, I don't think that should be the threshold for the bonus to set it at 4.08. I think we should still leave it at
And that's just threshold that you're thinking about?
Just a threshold, the
Okay.
others are fine. Would be my one suggestion.
Jill? All right.
I have a couple questions.
Sure.
On first year employee turnover, how does that break out into voluntary and involuntary?
This is voluntary turnover, not involuntary.
Why don't we also include involuntary?
Well, voluntary,
That is another judgment on our recruitment process.
it can be, but not necessarily, because involuntary turnover can be an employee who doesn't show up to work, who has issues that we wouldn't know about pre-employment. The benchmark out there for Saratoga is the benchmark that we utilize for healthcare HR metrics, tracks voluntary turnover, and then all types of turnover. But typically, voluntary is where you can make the impact, because what we're trying to do is impact that person to stay for an entire year.
Yeah, I would just also, maybe not as part of the official metric, but also track involuntary involvement. I think that's a strong statement on processes and procedures a lot too, because, you know, a lot of the healthcare organizations I've with, they also track that metric, simply because it gives you at least a qualitative understanding of sometimes your selection process and vetting process for folks. So, just a thought on that one, and then.
We do track that in the HR committee as a sub-measure as well, but yes, I agree.
And then, oh, the labor expense ratio, so, and forgive me, I come from higher education world, where grant revenue actually drives a lot of, your FTE costs. We hire a lot of folks directly on grant revenue. Is there a substantial or significant portion of JPS staff that's actually funded, to their employment side on grant revenue?
There's not a significant amount. We felt like it was important to include though, because what we don't want to do is get penalized for getting a grant that does support FTE, so it needed to be part of the calculation, but we do not have a significant amount of our workforce that is grant funded. Thank you.
Dr. Assad, are you fine with moving that threshold to 4.13? Yeah, I think we can support that.
I have one question on the patient experience overall from
Yes.
I think our stretch should be, you're at 78.9, your target should at least be 84, and then your stretch should be going up a little bit. I'm thinking around 80, I do 84 there. I really want your stretch to be at 90, but I know y'all gonna fall out on 7. That is where it should be. Because we're saying that we want this committee, and so I think your target is low and your stretch. So I would increase that target. I'd make that 80, I'm gonna go 85, but then I think the stretch still should be 90.
Can we go back to where we were in 25?
Yep.
And we do use Press Ganey to,
We have usually kept that one low, and then we moved it up, because I remember when we moved it up to 80, everybody fell out. But you have done a good job moving that, and I think it's one of the most critical ones, and so
can we do it by the same amount? I think that was about 4 and some above threshold. I think to move it up to
well, I don't remember.
85 or 90 is going to be, this really takes quite a bit. Go ahead.
So this is a really,
Yeah.
tough one to
Yeah.
move. I appreciate what you're saying, I really do, because I do think it's a super important metric for the hospital. But if you're looking at, like a target of 76 percentile, that actually equates to our, clinicians getting graded about 98 percentile on their Press Ganey scores.
Top box scores.
The top box scores. As the world has gotten better at Press Ganey, these are really like splitting hairs. So like when you're looking at 70%, 76%, you're looking at 76% of other clinicians in that area, not that we're scoring at 76. I don't know if our executive here is to elucidate, but probably the 76 is
Yeah, I mean, I would say like inpatient right now, baseline, we sit like in almost the 80th percentile rank, you know, for inpatient in particular. Outpatient surgery, we sit like almost 86th percentile rank. So those areas are high, yeah. The nuances do
I
get,
know, it looks like we're making C on this, but actually we're making A's.
Yeah, when you look
But
at the,
everybody's
yeah.
making A's, so national average, we're at 10%.
I do understand that, but you always, in this sport, it has been the 4 and 5 that's always mattered in this sport. So it isn't like this will change, the 4 and 5 is what you're targeting. And I still believe that you can increase your stretch.
I'm okay if you want to increase the stretch, but just, I don't know how realistic.
Let's go back to 26 then. I don't think we've ever hit stretch on patient experience.
You know, I know we have not met, we have not met at stretch. The goal is for you to move towards stretch. And as you get closer to stretch, you still improve that number. We may say it doesn't matter, but it does matter when you are looking at these numbers that says I'm at 78.9, and we are going up to, is that .1? Because we're at 78.9, so then we are going to add .1.
it's adding 2 to target and then 3 to stretch. So are you, Dorothy, saying 84 for stretch?
Okay. I just think that number needs to go up.
Okay.
As a pure layman in this area, this metric, is it based on comment cards, one-on-one interviews? Is it
It's a survey that they receive, and you,
done before they leave the hospital, after they go?
it's after they go home. Yep, they get the survey. In each one of the different areas, they have their surveys, and it is a top box score. So they're doing a ranking either from 0 to 5 or 0 to 10. Top box means you score an actual 5 on a 0 to 5, or a 9 or 10 on a score of 0 to 10. It has to be a top box. You don't get credit if you say, you know, 8 out of 10 times, you know, it was positive. You don't get credit for 8. So that's what top box means.
Every patient, no matter what they're here for?
They get,
Randomly selected, right? I mean,
yes, it's a percentage of the,
percentage of, yeah.
yeah, they get sent out.
What is the return on our survey?
Yeah, we have a low return.
To be low.
Yeah, low return. So denominator can be low, for sure. It depends on the different areas.
And this measures, they have to give us, you know, on a scale of 0 to 10, they have to give us 9 or 10 in order for us to get credit
Correct.
for this. So it's not like if you got 8 on it, that we would get credit for this. So this speaks to the percentage of people that give, yeah, the number of individuals who answer that with a top box score, which is 9 or 10.
The people are being surveyed, you said it's random?
The company sends them out randomly.
See, or they could be here for major surgery?
It's across the
It's across the
hospital.
whole hospital. Inpatient, outpatient, surgery, behavioral health, both inpatient and outpatient, as well as ancillary. So they come in for an x-ray, they get a survey.
Dr. Batamosi, do you have any comment about it? I know this is used for some of our quality metrics that we have financial on. Your time to defend as to where we should be.
Yes, we do use it a lot, and a lot of programs actually rely on the patient experience score, especially the HCAP score.
Any thoughts about
How to score.
where we set it and wanting to?
So just looking at the data, the level that it's set currently is actually quite aggressive. If we look at our comparators nationally, and I know George, who is over this, actually looked at, okay, where we are compared to other organizations and what is Press Ganey actually recommending as a target for FY26. As Jill correctly mentioned, this really looks at the top scores that is achieved across the continuum, not just in the hospital, ambulatory surgical center, in our case, Jessica, as well as behavioral health, and all of those get lumped together based on the weight of volumes that each department brings in.
Is this a survey that we developed, or is it national based?
It is a national, developed by the CMS, and and it's administered everybody that gets it gets the same survey.
Press Ganey is the vendor that sends it out, and they have a lot of clients, and they use their database for comparative analysis. So you can compare to like hospitals, you can compare across all types of hospitals. So they are the ones that we consult with as to,
Do we do follow-ups on any surveys?
You can, yep, you get the data.
Or do we actually follow up with the patient, say, why did you give us a one right across the board instead of five?
If they want to be contacted, that's a
They wanna be
question that they're
contacted.
asked. Yeah,
yeah. We try to do it in real time. We try to find out that someone.
yeah, before they leave.
Yeah, before
Yes.
Yeah, if there's something.
Anything we can offer, an incentive to make people want to do the survey back? I know when I do my business, we give cookies, boxes of cookies,
We-
all sorts of things.
Sometimes-
Fill out the survey.
Oh, you're talking about incentive to fill it out?
Is there
We're
something
not.
we can do, or maybe before they leave, be able to go over it with them? Is there anything we can do to get more feedback, better feedback, more accurate feedback?
Well, that's the work that George does across the organization is, I mean, that survey is set up as to what patients across the nation see as being indicative of having a good experience. And so the action plans that we have across the organizations are set up with that, with those questions in mind. But I don't know the cookie thing. We haven't tried that, but,
Yeah, I was going to say, send me your surveys, I can.
it is a fairly long survey as I remember it.
It is.
And so, and Dorothy, was it you that said that you start it and it doesn't save it or something? Was that you? Yeah,
I mean, there are some.
it's a little bit of clunkiness to it, yeah. So there can be a little bit of clunkiness, so,
It's not used error.
I was going to mention, you said it about saving it. But one of the issues, I'm not seeing, maybe I have the press gains, maybe I get it from my doctor. But one of the problems is, and that's what my concern is the length of that survey. And, you know, they say, you have a couple of minutes to do the survey. They're like, you never stop checking the clock.
and it's, that's going.
And so I think that, and then when you look at, the clientele that maybe are getting the survey, may not even have that patient or knowledge to go through it to return. And that's one of the things that concerns me is there's any way we could look at the survey to kind of simplify.
We don't develop.
We don't develop, and it has to be standardized. You've got to get the same one that our patient does so that we can compare, do the comparison. Jill or Dr. Batamosi, do you guys have any heartburn on lifting that to 84% for stroke?
Before you answer that, I want to make sure we also need to be very careful because we have a close to 50-year-old building. And we have shared room.
We're in it, and we have to still survey and get the satisfactory survey. It's gonna affect your pay coming back from vendors, from the insurance company. It is, we're moving forward. And I'll leave target, but I do believe stretch need to be a little bit higher. Stretch should be higher.
Well, Dorothy's comment too is that whether they fill out the survey or not, when you talk to individuals in the community, they speak highly of what they received at JPS. I had a couple of members who were in serious car accidents, and their family members couldn't stop raving about the service they received and the care at JPS. This was just recent situation. You know, the thing is now, when they get the survey, to convince them to fill out the survey, they might verbally say how well the service is, and I think that's where the problem is that vocally, community-wise, they'll talk about the service, and then do it when they get the survey.
That's the concern I have is that we have shared a room also as well. We have an old building, so sometimes they use that against us for us to pay attention, not to say that we are doing anything less, but it does have a problem with scoring. So, but
Dr. Holland?
Yeah, I mean, this is all stuff that we talk about in our office too. This is universal healthcare, right? Is to how do you capture the patients who are satisfied with the service and not just get those who have, a disgruntled experience and want to voice their opinion. How do you engage those that want to write positive things? And I think that's why we have, this is their job. But the long story of it is this is just extraordinarily hard stuff. And the fact that we've never met target on it makes me really I don't want to browbeat our team with a stretch that's just so insurmountable that they're not going to try. I want them to feel like they can make it if they really support efforts. It's like selling the survey, right? One of the things I tell my MAs, if they're if the patient says thank you so much for everything you did, I'm like, tell them to fill out a survey. The way you can help me back is by filling out a survey and, just engaging the team members to want to, to do this. And when you have a patient who's really grateful, saying the way you can show your appreciation for us is by filling out these surveys. And so just getting them to be excited about it rather than well, there's no chance we're ever going to make it, so I'm not going to care. Because Dorothy's right, this affects a lot of things. It's not just, national standards. I know JPS is so good at patient experience. This really matters for our Medicare contracts, that CMS 4-star. That's what this stuff really counts towards. And so we want the target and the stretch to be something that our team feels really empowered to reach. And the fact that we've never reached it, and this is higher than we've ever reached, I think it's a reasonable number from when I spoke to everybody. That's why I endorsed this number in particular.
Well, I mean, part of this goes into brand management, right? I mean, at the end of the day, these are the qualitative measures that we measure inside for reimbursement.
Yeah.
But one of the ways most organizations will have this conversation is to do brand equity surveys within the community, which will tell you what the community thinks of it. I mean, I know Johns Hopkins does them all the time. A lot of the bigger centers will actually go into the community and run these surveys and hear what the community says to essentially tell you hey, they go here because of this issue, but they choose not to go here because of this issue. So not to get us entirely off topic, but that might be something to consider with our relationship with the community, is to actually go out and see what our brand equity truly is and why people come here and don't come here, because a lot of that information is left out in these types of metrics.
Are we training our staff to ask for the same, as in ask for the survey, explain to our patient how important it is, not just for them, for us, for future patients? Please take the time, here's how it's done. Are we spending an extra 30 seconds trying to accomplish that?
Yeah, I think as part of the communication around the survey at the exit, we do encourage them, yes, you will get a survey in the mail. If you can complete it, that'll be great. The other thing with this survey is a lot of our patients that completed, they really, it's so onerous to complete, right? So they really have to have some form of really strong feeling either way to complete it. So that is why, looking at these metrics, just speaking technically, moving from 75 to 78% is really not the same lift as moving from 78 to 82%. And it gets harder. It's like rolling a snowball up the side of a mountain. The higher you go, the harder it becomes. That's the issue with HCAHPS, because to add those additional positives at such a very high level becomes increasingly difficult, even though mathematically the gap, numerically it looks the same, but it's very hard.
Alan, why don't we have, George is not here, he may be out on PTO, but why don't we have George, who oversees that work, come and speak to the board on just, I think you asked some excellent questions, kind of what do we do to encourage our our patients to take the survey, because we do want to hear from everyone. But let him come in and kind of review the work that's being done. And I think these are some great questions that can be better answered by him, if you would allow us to do that.
So let's get back to this one. Oh, what number are we gonna go by?
I'll remove my request, we'll just see. I will say, keep it at 81.9, because I've seen this before. We have had a number, we kept it there, and we never moved it. It happened that when we moved it up, we started moving again. So that's one of my concerns, that when we keep stretch so close to target, we don't move.
What was it last year, or what's the?
We started being 80, we got to 78.9.
75.6.
So we increased it from last year, and we increased our stretch this year anyway, so we are incrementally moving forward. And we think that's a good direction. I'm fine with those numbers right there.
What about the clinician engagement to 4.13?
Yeah, we're going to move that to
4.13.
For
Okay with that, Dr. Hall?
yeah, Dr. Sotz, yeah. She's over.
Oh, you
Yeah.
not quality, okay.
I support with that.
A question on this patient experience bundle, does it include anything other than the survey? It says bundle, so I assume it's
Bundle, I mean by all the different areas. So it includes inpatient, outpatient, surgery, emergency department, behavioral health, and ancillary services. So bundle means the bundle of the different care spaces.
but the sole source of the points is the survey.
It is totally the survey, yes,
The survey's pretty important.
yes,
Yes.
yes.
So we change it to 4.13.
4.13,
Then the other number, keep it the same.
Yes, yeah, the target stretch on the clinician engagement would be the same. Just the threshold would be what it was last year, was 4.13.
Patient engagement stay the same.
Leave it as presented, Dorothy.
Patient experience overall rating will stay the same,
Because
as is.
now, gone back to another one that said, we're gonna put it where the threshold was on that one. If we moved it back to where it was, your threshold for patient experience last year was 80, and you made it 78.9. So, it's fine.
For me personally, it doesn't matter, the stretching, it's very, very hard to achieve. All right. Motion to approve?
Second.
All in favor, signify aye. Opposed? Thank you.
Thank you, everyone. Thank you.
The next item is yours.
It is mine. Thank you. So I am coming here just to make you aware of some changes in the law and ask for some changes along to our purchasing policy that coincide with those legal changes. So as you know, we have a purchasing policy that governs the process by which we procure items and services on behalf of the hospital district. That procedure includes rules that are based on state and local government, code provisions, county purchasing guidelines, and board-approved authority. Currently, the expenditure amount that requires either a competitive procurement method or exemption is $50,000. On May 29th, 2025, Senate Bill 1173 was passed with an effective date of September 1st, 25. That bill amended several statutes to increase the competitive procurement threshold for governmental entities from $50,000 to $100,000. And so we are just requesting approval to amend our purchasing procedure to align with the revised statutory limits for competitive procurement.
Happens that the only change was 50.
To 100, yeah, that's why we didn't bring the whole procedure, because it's just to align with the statutory limit.
There was no other change. It's not in our packet. on our
It's
item,
not, because it was just
but it was
to
on the
align
board,
the,
But it had the actual, I guess the whole bill was there, the Senate bill.
yeah, they put the bill, but that's what the
Only
bill does. I'm
change
just
was the
summarizing.
amount.
Correct. They just, you can see, if you look at the red line to the various statutes, because the bill contained all of the references to the schools, the, different governmental authorities, and they just marked out 50 and put 100. And so that's what we would do.
Motion to.
I do.
All right, I'll move to increase our procurement limit for bidding from 50 to 100, consistent with the Senate bill.
Thank you.
Any discussion? None?
Yes.
All in favor, signify aye.
Aye.
Any opposed? Motion passed. The next item is the consent agenda. Second. All in favor, signify aye. Any opposed? Motion passed. And we are now the.
Yes, we have one legal update in closed session.
Would that work? Items on the agenda, the meeting's adjourned. Thank you so much, everybody, for coming.
We are
We are adjourned.
adjourned.